Good morning or good afternoon, colleagues, ladies and gentlemen. My name is Arthur Brandwood, and welcome to this webinar on ISO 10993, a risk-based approach to biological safety. Just a brief introduction of myself. I am the CEO and principal consultant of Brandwood Biomedical, a regulatory firm based in Australia and in China. And I have a particular interest and expertise in biological safety evaluation. I've been participating in the development of the ISO 10993 suite of standards for something like a little over 20 years since this activity started in the late 1980s, early 1990s. Before I begin, a little bit of housekeeping. You should be seeing a screen something like this, which contains both the slides and this little box here with an orange tab with an arrow on it, just to show you how you control your end of this webinar. This allows you to check your sound. It also allows you to enter any questions you might have as we go through the webinar. So if you have a question you want to ask, we'll do a Q&A at the end. Type your question in here. We'll collect the questions together, and then we'll do a question and answer session at the end. Okay, so let's begin. You're invited to a wedding. This rather cute Chinese wedding invitation. I selected Chinese because I happened to attend a conference in China about 5 or 6 weeks ago, where I participated in a workshop with the Chinese FDA and a bunch of industry experts drawn from the drafting committees in ISO that prepared the ISO standards. And I was quite intrigued that in that particular jurisdiction there is a real interest and willingness to embrace a more modern approach to biocompatibility testing based on risk management frameworks. And that's what I'm going to talk about in this webinar, is how ISO 10993 works and how it integrates with the risk management paradigms in ISO 14971. So this is really about a marriage of those two standards. And like all good marriages, there's already a child. There is a technical report prepared by the ISO Technical Committee 194, published last year, ISO TR 15499, and this really is a guidance document. It sets out how to do a biological evaluation, how to apply ISO 10993, and how to do that within the framework of medical devices risk management set out in ISO 14971. And this webinar will really be setting out in summary form what's contained in that guidance, so it follows that guidance. I had the pleasure and the honor of being involved in preparation of the guidance and chairing the working group that wrote that. So here's our agenda. Firstly, I'm just going to take a quick look at the group of standards, ISO 10993, its parts and how they all fit together. We'll then move on and look at how the risk management paradigm fits with that. We'll talk about some specific things, particularly understanding exposure to medical devices and the biomaterials and how that affects risk analysis. We'll talk about how we understand our device and the materials within it. We'll talk about testing, and testing as a supplement to knowledge, not as the starting point. So we'll work through our risk analysis and gathering information first, and then we'll ask the question, well, what testing do I need to do to add to what I already know? We'll then talk about briefly how we pull all this together in a final biological evaluation expert report, which provides your evidence for biological safety. And then we'll finish by summarizing the overall process as set out in the ISO 10993 standard and in the associated guidances. So let's begin with 10993. It's a group of technical standards. It provides high-level guidance on how to conduct a biological evaluation. and I'll just move on. I seem to have a duplicate slide here, my apologies. It's a group of standards. It provides a high-level guidance on how to conduct a biological evaluation. It provides detailed test methods for investigation of different aspects of biological safety. It provides supporting guidance on materials characterization, the use of reference materials, on animal welfare, and a whole bunch of other things. And within this body of standards, there are multiple references to other test methods and guidances contained in things like National Pharmacopoeia and national standards. And this whole body of work has taken about 25 years to develop. The ISO Technical Committee 194 was founded, I think, in 1989 or 1990. And so it's been going along for some time and developing standards, and many of these standards are in the third or fourth revision. So here's how they all fit together. The parent document is ISO 10993 Part 1, the evaluation and testing within a risk management process. This sets out how to plan and develop a strategy for your biological evaluation. It provides detailed guidance on how to characterize devices in terms of the nature and duration of contact with patients and users, and to identify which specific aspects of biological safety should be considered in the evaluation program for any specific device. And then subsequent parts are numbered ISO 10993 Part 2, Part 3, and so on. And I should just say the numbering is not in any particular order. It simply reflects the sequence in which the parts were written and the numbers were allocated by ISO. There are 8 separate parts which provide detailed guidance on the wide range of test methods which may be used in testing activities to support biological evaluation. There are Parts 8 and 12 which speak to reference materials. When you're conducting a biological evaluation, it's often useful to have a well-understood reference material to use as a control. Both positive and negative control reference materials are available. And Part 12 speaks to sample preparation and use of those reference materials. Parts 9, 13, 14, 15, and 17 all speak to working with degradation products, how to identify and quantify degradation products. Parts 9, 13, 14, and 15 speak about both the overall framework and then dealing with polymers, ceramics, and metals. They could have all been put in one part, some would argue, but this is how it's been developed. And then Part 17 provides a specific framework on establishment of allowable limits for leachable substances. Parts 18 and 19 provide specific guidance on chemical and physical characterization of materials in medical devices and references to a whole lot of technical methods that can be used for characterization. Part 7 is a quite specialist and unique part of the whole series. It's the standard which deals with specifically with ethylene oxide sterilization residuals, and that's the standard where you'll find the current internationally acceptable limits for sterilization residues. And Part 2 finally sets out the requirements for animal welfare when doing animal testing. So, moving on from that, it's important to remember that biological evaluation is an activity which is both part of design and part of risk management. The activity is subject to design control processes and forms part of the risk management of the device. And looking at some of the different standards that impact on the process, so if we look at ISO 13485, the International Quality Management Standard for Medical Devices, biological safety requirements are a design input. We need to ask the question, what are the specific biological hazards and risks in my application? Compliance with biological safety is part of design verification. So the question needs to be asked, how do I show that my device meets acceptable levels of biological safety that I've defined as part of my design inputs? And then under ISO 14971 in risk management, we need to deal with biological risks in the conventional risk management framework. We do risk analysis to identify the biological hazards. We do evaluation to determine the level of risk. We can apply risk controls to mitigate biological risks, and we can build on knowledge through post-market, post-production monitoring. And all of this needs to be planned. Planning is essential, and it's a mandatory part of how you do this, and that's spoken to in several standards. ISO 13485, of course, speaks to planning of design and development processes. 14971 requires that you have a risk management plan, and ISO 10993 itself says that the biological evaluation shall be planned and carried out and documented. And it also points out that this needs to be done by knowledgeable and experienced professionals. This is not a trivial undertaking. It does require specialist expertise to conduct a biological evaluation program. But the whole thing needs to be planned, and of course you don't need 3 separate plans. You need a plan which speaks to the requirements of all of these standards. This is addressed in regulation as well. So if you're seeking, for example, CE mark, Essential Principles 2, which deal with risk management, and Essential Principles 7.1, which deal with biological and chemical safety, set out requirements for doing biological evaluation and risk management, and what you do in doing the biological evaluation is part of the evidence demonstrating compliance with those essential principles. And in the American regulatory system with 510Ks, for example, there is a whole separate section in the standard 510K format on biocompatibility. So what is biocompatibility? This is an old definition now, written by David Williams in his Dictionary of Biomaterials back in 1999, where biocompatibility is defined as the ability of material to perform with an appropriate host response in a specific application. And it really implies both absence of unacceptable effects and presence of desired host responses. The first is really safety, and the second is about performance. 109993 mainly deals with safety by consideration of the toxicity of biomaterials used in devices, although I would note that desired host responses or performance has to be considered as well as part of design verification of a device. So you are dealing with both sides of the coin. But 10993 standards really are particularly emphasizing safety. So what matters? Really, biocompatibility boils down to a consideration of toxicity associated with materials used in medical devices. And there are really 3 things that you need to consider for any given device. We need to consider the time, how long the device or material spends in contact with the patient or user. We need to think about location, or more specifically the level of invasiveness, whereabouts the device contacts the user or the patient and the tissues. And we need to think about how much. What is the quantity or dose of potentially toxic material which finds its way into the tissues? So let's look at how the standard deals with those 3 things. Firstly, duration. Part 1 of the 10993 sets 3 bands, if you like, of exposure times. Band A, limited duration, is less than 24 hours. Band B, prolonged, is 24 hours to 30 days. And permanent, Band C, is anything exposed for over 30 days. Now, I just make a quick note that these definitions of time bands don't align with others used, for example, for device classification purposes in the medical device directives and other GHTF-based regulatory systems. Just as an aside, that does sometimes cause some confusion when people are thinking about device classification as well as looking at the more specific subject of biological evaluation. Then we think about location of the patient or user contact. And again, the standard breaks this into groups. It talks about surface contact, for example, contact with intact skin, such as compression bandages or electrodes from ECG devices, mucosal contact for things like intraoral devices, colonoscopes, or compromised skin, wound dressings. Then we have external communicating devices, either things like the devices which connect indirectly through the blood path, such as blood or fluid giving sets, tissue contacting, such as surgical instruments which communicate into the tissues temporarily during a surgical procedure, and devices which contact circulating blood, such as dialysis equipment and intravenous catheters. And then finally we talk about implant contact, things that go into the tissue, such as orthopedic devices, or into the blood, such as pacemaker leads, ventricular assists, and other cardiovascular devices. Now, part 1 of the standard sets this whole thing out into the table A1, this big table that exists towards the back of the document, and you can see here we have the 3 categories of invasiveness: surface, external communicating and implant, which break down into some subsets, and then the duration, bands A, B, and C. And then for each potential combination here, the standard provides advice on what you need to think about in terms of the potential biological effects. So, for example, if we look at a device that's intended for long-term contact with a breached or compromised surface, such as a wound dressing for a persistent ulcer or other long-term contact with a wound, we'd be in a surface device, breached or compromised surface, band C, permanent contact. We add up, by the way, the cumulative contact. So if you're changing many dressings over a period of a month or more, you would be in this over 30 days. It's not the individual contact time for one dressing, it's the cumulative effect of all of the uses of that type of device. Then it says, well, we need to think about cytotoxicity, we need to think about sensitization, we need to think about irritation for that device. We also should be thinking of subchronic toxicity and genotoxicity. These are the different toxicological endpoints, if you like, which are likely to be relevant to that device. I emphasize that this is not about doing testing. It's saying we need to understand these types of effects. We may already have information, and we'll come on to that in a little while. But then just looking at another example for a short-term contact device in the bloodstream, we have cytotoxicity, sensitization, irritation, but we also add systemic toxicity, we add genotoxicity, potential for implant studies, and of course hemocompatibility. So we can see the different examples. Now, this table has been subject to revision and reinterpretation in a well-known guidance from the United States FDA called General Program Memorandum. It now dates back to 1995. It refers to the to an older version of the standard, but essentially what it does is it adds in some further advice to consider some additional things. So the little red zeros here coming from the FDA guidance say, well, in the view of the United States FDA, there is need to consider some additional endpoints. So if you're planning a biological evaluation, it's well worth taking a look at this guidance as well, because there is a different point of view as to what you need to think about. And certainly if you're planning to take a device to the United States and you're subject to a regulatory review there, then the agency is naturally going to expect to see that you've considered the additional things that they set out in their guidance. But as I said, this is not a checklist. This table has been used as a checklist. It's specifically not. In the latest version of the standard, there's some additional language which emphasizes that this is guidance for what you need to consider in your biological evaluation. It is not necessarily a list of things to test, and I sort of call that a bit of a testing trap. It's very simple to just read the tables, carry out the tests. That's what many people will do as they're in their approach to biological evaluation, but that's really not a good idea in a number of ways. It's expensive to just do all that testing. It can be wasteful. It can slow you down, waiting for all the tests to happen. It can be unethical, because if you've got other information already existing, then you shouldn't be doing unnecessary animal experiments. And finally, it really doesn't allow you to think. You may miss some specific aspects relevant to your device which are not covered in the table or which need some modification. Okay, and tests are not foolproof. Some biological tests will miss things which will be picked up in other ways. For example, chemical analysis can sometimes be quite a lot more sensitive than a biological test. So the standard actually considers this. Clause 6.2.1 of the ISO Part 1 standard says testing shall not be carried out where results are available from relevant previous studies or existing preclinical and clinical data, including history of safe use, which demonstrates that the device meets the requirements for biological evaluation. So the standard itself completely considers this, that we don't actually necessarily need to do all the testing. So how do we deal with that? And the answer is that we need to conduct our biological evaluation within a risk management framework as set out in ISO 14971. And the rest of this presentation I'm going to look at that. So let's just quickly refresh how 14971 works in the risk management paradigm. I'll just remind you that 14971 sets out a risk management process which begins with risk analysis, where we consider the intended use and intended purpose of the device. We attempt to identify hazards, and we attempt to quantify risks or estimate risks associated with each of those hazards. We then go on to evaluate which of those risks are acceptable, and we make some decisions about acceptability, and that whole process is called risk assessment. And then we may apply risk controls, we look at what options are available, and we implement controls to reduce risks, to mitigate risks, and we consider what risks remain after that process and what is the overall risk acceptability level for our device in its final form. And then we place the device into the field, we place it on the market, and we learn from post-production information from our experience, and we will review risk management as we go along. Okay, so that whole process together is risk management, and I emphasize that it's an iterative learning process. It's a cyclic process, it's a living process, and as we gather information through design and through experience in the field, we go back and we update our analysis and management program as we go along. That's ISO 14971. How do we then apply that to biological risk management? Well, the first thing, let's just step through this. We start by identifying the intended use and purpose of our device. We need to understand the device. We ask, how is it used? We think about the duration and location of contact as set out in Part 1. We can consult the table A1, and don't forget the FDA G95-1 memo. And we can consult more specific regulatory guidances and product standards that might apply to our own medical device. We might want to think about particular factors. For example, a device that's placed into the mouth may be in contact with the oral mucosa, so we may want to think about specific dental mucosal irritation testing. There are separate protocols designed for devices intended to go into the mouth, and if you go to the dental standards, the dental device standards, you'll see references to specific tests. So again, we need to think about our particular device and how it's used. That then allows us to define a set of acceptability criteria. So we're now providing as design inputs what it is that we need to think about. We've consulted table A1, we've looked at which particular endpoints we're going to look at, for example, irritation or sensitization or blood compatibility. We then say, okay, our device needs to meet acceptable standards of safety for each of those endpoints. That has now given us a set of acceptability criteria. And I point out that safety is not absolute. This is really a diagram of what safety means. Safety means that the benefit is greater than the risk. The benefit is heavier than the risk. So here we have this picture of the kids on the seesaw. Benefits need to be greater than risk, and that defines safety. So it's not an absolute. There will always be some risks, and we need to think about that in terms of the contact of the device. And this is a slide I often put in front of a bunch of students. and ask the question, okay, what's the acceptable risk for these two medical devices, the heart valve on the left and the wound dressing on the right, the simple sticking plaster? And of course, it's quite common for people to say, oh, well, the heart valve, that one needs to be far safer than the sticking plaster. But when we think about heart valve surgery, the rates of mortality, the number of people who die from the effects of having a heart valve implanted, is of the order of 1%. Depends on the procedure. It can approach 3 or 4 or 5% for some particularly difficult subgroups. I don't know what we would find if of the order of 1% or even more of patients who applied a sticking plaster were to die from the results of use of that sticking plaster. But my point is that we tolerate higher levels of risk when we have higher levels of benefit. Clearly, the heart valve is providing a high degree of benefit because patients who require heart valve surgery are at risk of dying from their underlying heart disease at the rates of tens of % a year compared to the lower rate in heart valve surgery. And the same principle applies to biological evaluation. We need to think about the biological endpoints, think about the potential toxicities, and weigh those up against the benefit of the device. And we may be, for example, prepared to accept a certain level of hazard associated with hemocompatibility issues in biomaterials used in heart valves because of the benefit that that heart valve brings. So, understanding the device, we need to characterize the device, characterize and understand the materials used in the device. That means both the bulk material and also all the other things that come along with it. So any additives in the material, any process aids that may have got into the materials during manufacturing, any contaminants that may have gotten into the materials during production, and any degradation products that may arise while the device is in use. And we ask ourselves how much of each of those there are, because that's the question about dose. How much of each of these things is actually available to the user or the patient and ends up contacting the tissues? That's the third part of the equation, the dose. Where do we get this information from? Well, a good place to start is the manufacturer data from our material suppliers. They will often be able to tell you the formulation or provide information on what's present in the material, or we may do our own chemical and physical analysis. And I refer you to parts 18 and 19, as I talked about earlier. They provide detailed guidance on doing materials characterization, and parts 9, 13, and 17 for guidance on degradation products. And we may also look for compliance with material standards. There are quite a number of standards for things like alloys, for things like polymers used in medical devices. For example, there are standards defining the polyethylenes used in orthopedic devices, and we look for compliance with those standards. So then we need to identify the hazards. We firstly say, well, what's the known toxicity of each of the material components that are available to the tissues? What kind of toxic effects are known, and are they relevant to the use of my specific device? And what's the dose-response relationship? Where do we find out that information? We need to think about the availability, the rate and pattern of release, and the total patient exposure. I'm just going to move on and say, well, firstly, where do we find out? What do we already know? We've got perhaps data already existing on earlier generation devices. We have perhaps data on other similar uses of these materials and additives. We may have our own testing data on the materials in-house. We may have data from the manufacturers. Often specialist suppliers of medical grade materials will have their own testing data on file, which may be relevant, and we may go to the general scientific literature. We need to understand the toxicology, and we may refer to, for example, the ToxNet database maintained by the National Library of Medicine, the National Institutes of Health, a very useful searchable database where you can take each of your materials components and search within that database to provide a current and reasonably up-to-date body of knowledge on what's known about the toxicology of each component. We need to think about the routes of administration. Are we talking about oral administration? Are we talking about skin contact? Are we talking about inhalation? Are we talking about something that's in direct contact with the tissues through an implant? And then we look within the literature or all of our sources of data, and we ask, well, what do we know about the thresholds of adverse effects, if you like? We can look at things like no observable adverse effect levels and lowest observable adverse effect levels. These are the thresholds above or below of which we do or we do not see an adverse toxic effect from a specific material or substance. And we can compare these to the known quantities and release profiles in the device. And that then starts to tell us whether we've got something we need to worry about or not. If the materials are below the NOAL or the LOAL, then usually you've got a good argument that the particular substance is not going to be of biological concern. Having done all of that, having looked at the existing data sets, we ask the question, do we know enough? Is our existing knowledge enough to understand the biological risks applicable to the device use? And if not, we might need to supplement that existing knowledge and carry out some testing to fill the gaps in the knowledge. And when we do that, we're then going to follow the guidance of the appropriate parts of ISO 10993, which provide the test methods according to the different endpoints and different aspects of biological safety that we're considering. We compare the test results to those acceptability criteria that we set up at the beginning. We're basically saying, well, we want acceptable levels of cytotoxicity or sensitization, freedom from sensitization, freedom from irritation. We compare the results to see if we've got test results that show that we've got the desirable outcomes. Now, when we do that, we're conducting the testing. Remember, we start with the appropriate planning. We need to think about which test protocols we're going to use. We select the protocols and controls as per the ISO 10993 parts, and we consider also specific product-specific guidances and regulatory guidances. Many product guidances and product standards will have specific information within them that talks about what tests you need to consider. For example, if you go to the FDA guidances on medical gloves, you'll find their guidance on what biological evaluation should be considered. If you go to ISO standards for specific products, you'll find guidance on what biological evaluations are important. So you can look at, for example, the ISO standards for things like heart valves or for stents. They will talk about what you need to consider in terms of biological evaluation of those devices. And finally, I should just point out that you need to conduct the final testing under good laboratory practice. That goes without saying. And commercial test houses which offer biological evaluation will all do that, or you should select a test house, most of them do, which offer GLP testing compliant to ISO 17025 or to the FDA 21 CFR 58, which are broadly equivalent standards of good laboratory practice. So now we have considered the literature, and we've considered our in-house and material supplier data, and we've carried out whatever additional testing to complete our knowledge, and we proceed to the risk evaluation, where we need to decide if the biological risks, as indicated by pre-existing data and testing outcomes, are acceptable. If the known toxicity of a materials component is within the predefined acceptance criteria, and then we've established a biological safety for that component. If not, we need to consider risk control. So how do we do that? Have we, for each of the endpoints we're thinking about, have we met our acceptance criteria? In which case, yes, we've established biological safety. If not, then we might need to consider risk control. So if we are getting some adverse results from our testing, or if we've got data that suggest particular components are not safe, then we need to think about risk controls. And we do this for each separate aspect of biological safety under consideration. If the table A1 suggested 3 or 4 different things we need to think about, then we need to do this and ask this question for each of those separate aspects of biological safety. So what sort of things might we be looking at for risk controls? These are just a bunch of examples here for some of the options that we might have for risk mitigation. If we're seeing, for example, levels of sterilant residues which are too high, we may need to reconfigure our packaging or our sterilization protocols to reduce the level of residues. We may need to reconfigure a mold in order to avoid the need for a mold release agent if we're getting problems from contaminations of mold release agents in a molded product. So they're design changes. We may need to change materials or additives, for example, substituting a less toxic catalyst. We may need to introduce manufacturing controls to mitigate risks. A good example of that is the very conventional process of batch-released pyrogen testing for devices which are implantable or in long-term tissue contact. We may need to introduce inspection or testing of raw materials or of finished products to confirm their formulation and confirm specific substances within the material and the levels of those to make sure that we're below safe levels of, for example, contaminants. Or we may need to provide warnings, and perhaps the best known example of that is the commonly provided warning labels on natural rubber latex products to do with dermatitis or the risk of anaphylaxis on things like medical gloves. And that, of course, is in compliance with Essential Requirement 2 in the Medical Device Directives, which talks about one means of mitigation being provision of warnings. And then we place the device in the market and we learn, iterate and develop our knowledge. Remember that, like all risk management activities, this is a continuing and living process. Now, we may through our trend analysis and looking at adverse events, see that we need to update our risk assessments because we learn things in the market we didn't anticipate or we didn't detect in the testing program or in our original biological evaluation, and we then may, if necessary, go forward and change materials or design as we update the risk assessments. And we update our biological safety evaluation. And it may be possible to restrict the scope of what we're doing to consider a specific change in a material or in a particular component of a material if we, for example, have discovered that we've got an additive in a polymer that's causing an adverse biological effect. We may then need to do a rather restricted evaluation that focuses on the adverse biological effect we've detected. If we've got something that's causing, for example, sensitization reactions, then we may want to reformulate and focus on the sensitization of the new sensitization safety of the new formulation. And finally, the entire biological evaluation process needs to be documented in a biological safety report. There's no specified format for this in ISO 10993 or in any regulatory guidance. However, the content will need to look something like this, and it follows the sort of logical progression of the evaluation process. We need to start by documenting the plan, describing the evidence and its application, and setting out the predetermined acceptance criteria for biological safety. Now, remember that that's going to be primarily based around the specific areas for consideration identified in the Table A1 and the FDA Blue Book Memo G95. We then need to we need to document the detailed materials characterization that we may have done. We want to know about what are the specific formulations of the materials in our device, what manufacturing processes we've used, what chemical characterization we may have carried out, or physical characterization, and what do we know about things like degradation products and leachables. We will need to as well include the review of external data, what we've looked at in the literature, include the search strategies that we've used to search the literature and locate data. It's always important to include the search strategy in a literature review so that anybody who's reading or reviewing your report can understand and be clear that you've been objective and comprehensive and appropriate in the selection of literature. We may include our own in-house data, and we may include data we've obtained from the materials manufacturer. And then we include the testing we may have done to supplement the body of knowledge, and we'll need to include there the details of protocols, acceptance criteria, the results and discussion of the specific testing activities. We can then document that in terms of risk evaluation and risk controls applied, so bring this all together, any particular changes we may have made to mitigate risks, any labeling warnings that we've applied, and whatever residual risks may remain after the biological evaluation has been conducted. Remember that the risk management framework requires the documentation of residual risks within a medical device. And then we can draw to our conclusions about the biological safety of the product. So all of this comes together as a biological evaluation report. And it does need to conclude with a formal statement about the acceptability of the biological safety of the device. So let's look at that as a process. It looks a bit like this. We begin by considering the clinical application and the biological risks. We go on to characterize our device, and more specifically we characterize the materials within the device, and we consider existing data, both from the literature, from our in-house data, from the manufacturers. And we ask ourselves, do we have enough knowledge and information to be able to proceed to an evaluation of the risks? If the answer is yes, we proceed to evaluating those risks and documenting. If not, then we can do supplementary testing to fill the gaps in the knowledge. Now note that the testing is not at the beginning of the process, it comes well into the process. We don't start by going out and ordering tests, we start by considering the materials and considering existing data. And then we only do testing if we conclude that we don't have sufficient knowledge to evaluate. We apply required risk controls. We may need to go back and do some additional testing if we've made modifications in doing the risk controls. If we've changed materials, if we've changed designs, we may need to add some more testing to fill gaps in the knowledge following that change. And eventually we prepare our report and lead to conclusions. And that whole process is set out in part one in this slightly more complex chart. The chart I've just shown you is really a simplified summary of this chart that exists in part one, where we can see it starts off by again asking, well, what do we know about the material and the chemicals and the characterization considered, asks a bunch of questions about that, and then says, can we do a risk assessment? If so, go and do it. If not, do some testing, and here are the test selections right here. We do the testing at the end of the process, and then we perform our evaluation. So, in summary, a risk management approach provides a framework to conduct a biological evaluation. It causes you to build a comprehensive understanding of your device and the materials contaminated and any materials which contaminate that device and their interactions, and how to develop a robust knowledge base to establish safety. I remind you, don't fall into the testing trap. Begin with a risk analysis, know your device and materials within it, and draw on the published literature and information available from materials suppliers. So know the materials and interactions, draw on that published literature, and then decide what you don't know. Identify the testing needed, do the testing to fill in any gaps in your knowledge, and by taking this approach, it also provides you a framework to justify not conducting testing when you've got sufficient relevant pre-existing knowledge. Proceed to a risk evaluation, review all of the information, both external and information from your test results, and quantify the risks. If required, take steps to reduce toxicity to acceptable levels by changes in materials or in design, and then consider whether you need to do further testing to verify the effectiveness of the risk controls applied. And then finally report, document the entire process, and justify the acceptability of risk in the context of the clinical application. So I'll conclude there. As I said, we have a marriage of three. They walk together. We have the ISO 14971, we have ISO 10993, and don't forget that 15499 technical report, which provides you the guidance on how to do all of this. Okay, so at this point, it's time for questions. I'm happy to take questions that we may have received. And I'm just looking here, bear with me while I pull up the questions on my screen. So the first question I have is, what do you do when we've got proprietary ingredients? A common challenge is when materials contained within a device may be proprietary. For example, you've got a pigment or a polymer which you're obtaining from a material supplier, but the formulation of that material is proprietary. There are really a couple of ways you can deal with that. Firstly, the manufacturer of those materials may have their own testing data. Even though the formulation is proprietary, they may have conducted testing. They may have established the biological safety of their material when used, when processed in certain ways, and you can ask the question, well, have I processed the device within the parameters specified by the material supplier, and use the recommended sterilization protocols, for example, as well. If that's the case, then you may have an argument that the material safety data supplied by the manufacturer provide support for the safety of that material, or you may need to conduct your own testing to supplement it. But also, most regulators have a means or a process by which you can arrange for the material supplier to supply directly to the regulator what's called in the United States a master file, where the material supplier files with the United States FDA their proprietary formulation information, which is filed confidentially with the regulator. You don't get to see it, but the regulator gets to see it, plus testing data that they may have obtained in conjunction with that particular material, and that can then be reviewed by the regulator in conjunction with the review of your medical device. Now I have another question here from Romit, which says, and I'm just reading out the question, just by using a risk analysis approach, how do you address essential principle or essential requirement 7.1? Supporting documents requested during a submission. So essential principle 7.1 essentially says that a device or a manufacturer of a device needs to demonstrate both the biological and chemical safety. So really, this whole process is satisfying the requirements of 7.1. But if you, for example, have based your biological evaluation on existing knowledge with a limited amount or no testing, then the supporting documentation is really the biological evaluation report. That evaluation report is the primary evidence for the device verification against the input requirement of biological safety. So that is the document which needs to be in the technical file. That's the document that needs to be submitted to the regulator as the primary argument. So it's not a matter of submitting test certificates, it's a matter of submitting the biological evaluation report, which may be supported by test data or may not. Okay, just looking for other questions here. How old, I have a question here from Anita. How old is in-house testing acceptable? And I'm assuming that question really is talking about the age of data that you may already have, and yeah, how old is in-house testing data acceptable from Anita Sawyer? Thank you, Anita. Really, data which are applicable to the current formulation and have been done under good laboratory practice should remain acceptable. It has been experienced that some regulators like to see more recent data, but it should not normally be necessary to repeat data just because they were done a long time ago, providing that you can be confident that the current materials formulation is the same as the material that was tested in the old test results. Okay. And I have somebody, Dustin has just said, hang on, what was the guidance reference again? I just refer to that again. It's ISO Technical Report 15499, which is guidance on the conduct of a biological evaluation within a risk management framework. So ISO Technical Report 15499. Okay, and then finally I have a question about what about the acceptance of this biological evaluation approach in different markets. I started the presentation with the kind of cute Chinese wedding invitation. I know that biological evaluation is dealt with differently in different markets to a certain extent. All of the major markets accept ISO 10993 as the basis for biological evaluation, but the interpretation of that does tend to be a little different. Certainly it's been experienced that in the United States there tends to be a greater expectation for testing data to be provided and less reliance on pre-existing information. However, providing that you can justify in an expert biological evaluation report that pre-existing information is relevant, and it needs to be relevant in terms of not just the same formulations of materials, but that the materials were processed and sterilized and handled in the same way and don't include any additional contaminants. If you can justify that, then it is generally accepted by, for example, the United States FDA that you can establish biological safety on the whole body of knowledge. And as I referred to recently, some of the emerging jurisdictions are very much signing on to this risk management approach, and certainly at the recent seminars in China, the China FDA and the associated test laboratories in that jurisdiction are showing a great deal of enthusiasm for taking on this approach of using a risk management model of considering the whole body of knowledge and not just doing testing. So that was very encouraging. Okay, at the end of that, I think that's all the questions I have received. I don't have any more, so I'd like to thank you for your attention. I trust that this has been a useful webinar setting out the overall framework for biological evaluation under ISO 10993 and according to the ISO 14971 risk management paradigms. Certainly, if you'd like to ask any further questions, I'd be entirely happy to receive an email or email request, and please do come through to us. And thanks again for your attendance. Good day.